Well, I hope this finds you in a good health, and I would like to welcome you to the ICU case presentation on end-stage renal disease with electrolyte imbalance, elevated creatinine, and BUN levels. Previously, we had a presentation on standard operating procedures on end-stage renal disease on dialysis. It was the nutritional management, but as today we're going to have this case study, and it will be very helpful to understand all those standard operating procedures practically. You'll be with me, Gilbert Gaston Charles, your clinical nutritionist and dietitian from Tanzania. Well, end-stage renal disease refers to the final stage of chronic kidney disease where the kidneys have lost nearly all their function, resulting in the inability to adequately filter waste products and excess fluids from the blood, usually with the glomerular filtration rate less than 15 mL per minute. Patients with end-stage renal disease typically require dialysis or a kidney transplant to survive. It's a serious condition that requires ongoing medical management and treatment. Let's take a look at the signs and symptoms that we already talked about in the previous presentations. Patients with end-stage renal disease, they always present with edema, shortness of breath, loss of appetite and weight loss, anuria, difficulty in concentration and mental confusion, muscle cramps and twitching, itching, weakness and fatigue. Well, with a 42 years old male patient who is a businessman, married, and is a middle class social status, whose close relatives are wife and sister, admitted on 17th January 2024. He's a Christian, but also education level is a university graduate. Well, the patient is a known hypertensive patient, diagnosed in September 2023 at one of the hospitals in northern Tanzania. However, he reported to have been skipping medications due to his tendency on alcohol consumption. On January 2024, he experienced a heart attack and was admitted to a cardiac institute for further management. Upon discharge, 5 days later, experienced a difficulty in breathing and was then admitted to the National Hospital ICU for further management, where he presented with pulmonary edema and consequently end-stage renal disease. He has family history of hypertension from a first-degree relative, that's the father. He has been drinking alcohol for more than 10 years. The medications that were prescribed to this patient were IV pantoprazole, 40 milligrams OD, and this can consequently affect the vitamin B12 absorption. Nifedipine, hydralazine, clonidine, furosemide, all these have their drug nutrient interactions too that we need to understand in the background of it. Also, the patient is on dialysis three sessions per week. So what I had to do right now here is nutritional assessment. What do we do first? As how we talked in the standard operating procedures for nutritional management on end-stage renal disease patients on dialysis, we need to get these anthropometric assessments. Post-dialysis weight, that was 61.5 kilograms. The adjusted body weight from the NANES data was 65.1 kg. The height of this patient is 169 centimeters. The knee height is 51 centimeters. So we got the height from the knee height. And also the biochemical assessment, we have the parameters on BUN, creatinine, potassium, sodium, HB, calcium, magnesium, and phosphorus. All these parameters were taken for measurements. And the red color represents a value that is higher than normal, and the blue ones represent values that are lower than normal. But also the green one represents a normal reading. Yes. So as you can see, we had high BUN levels and high creatinine levels. But on the first assessment, as you can see from the BUN was 45.7, and on the second assessment was 44.5. It reduced a bit. The creatinine levels had reduced dramatically from 2,497.1 to 2,099.6. Potassium levels were quite very high on assessment, but on reassessment there, this means that on reassessment is after having a management on this patient. It was 3.3 on the other day. Sodium was constantly low, but also HB level. The HB level was 14.3 and next was 14. We can see these patients on the patients having end-stage renal kidney disease mostly may present with anemia sometimes. So you can see the HB level just going low a little, but we're trying to manage it that he will not have anemia because the erythropoietin is being disturbed here. Yes. Calcium was 2.28 and was later 1.35, down a bit. But also magnesium were very high at first and then normal at the second time. The phosphorus levels were very high at the first place, but on reassessment were 1.2. Well, on the clinical assessment, the patient was drowsy on assessment and fully conscious on reassessment, so he was fully conscious later after the reassessment on the other day. He was a febrile, not jaundice, not pale, and also had a non-pitting edema, but also the saturation percentage of oxygen was 98% with blood pressure 150 by 89. This is systolic versus diastolic millimeters of mercury. On dietary assessment, the patient feeds orally without complications, has good appetite, no food allergies or intolerance. It is very important to assess all these factors such as allergies, intolerance, so that you may know what would you actually include on the meal of your patient. Also has not been on nutritional supplements before. Feeds on regular 3 meals and 1 to 2 snacks in a day, but also the patient had a general nutrition recommendation from a previous admitted hospital before coming to the national hospital, and also he has history of alcohol consumption for more than 10 years, but no history of smoking cigarette. Also has history of consumption of fried meats, and this can actually tell us it gives us a glimpse on why this guy also had hypertension. Fried meats go very well with high salt consumption, and excessively continuous high salt consumption is a risk for hypertension too, and also has history of high salt consumption. That's the last bullet. So on the nutritional diagnosis of this patient, he had high levels of BUN and creatinine related to the end-stage renal disease, as evidenced by the altered laboratory results of BUN and creatinine, which were quite very high than normal, and also electrolyte imbalance related to end-stage renal disease, as evidenced by the altered laboratory results of hyperkalemia, hyponatremia, hypermagnesemia, and hyperphosphatemia. All these were evident on the lab results. So on the part of goals, what were our goals on managing this patient? Of course, we had this patient in ICU and we had to come up with very good goals for this patient. Our first goal is controlling or targeting lower levels of BUN and creatinine levels. As we know, for end-stage renal kidney disease patients, we need to keep the control of BUN and creatinine levels at lower levels. Correcting electrolyte imbalance. This is very, very, very important. Avoiding the hyperkalemia state, which can lead to cardiac arrest and some other more issues. But also fluid restriction. According to Kidoki guidelines, one of the goals is fluid limitation or controlling fluid intake and restriction. Also, prescribing adequate protein and energy with reference to dialysis adequacy. So the objectives were limiting sodium intake to 1,000 between 1,000 to 3,000 milligrams in 24 hours. Also limiting potassium intake to 1,000 to 1,700 milligrams in 24 hours. Limiting phosphorus intake at 10 milligram per kg because our patient was having high phosphate levels. But also vitamin D and calcium supplementation. As we all know, the vitamin D activation occurs in the kidneys, and It is very important for these patients on end-stage renal disease to have vitamin D supplementation and calcium. This is to these patients get vitamin D that is activated, but also for calcium reabsorption and absorption. Yes. And also limiting protein requirement at 1.1 to 1.2 gram per kg per day. This is according to Kidoki guidelines, because our dialysis patients, the protein requirement usually goes high a bit because of the raised metabolic requirement for these patients due to dialysis, and also fluid restriction to less than 1,000 ml in a day for this patient. Of course, energy requirements for this patient were 30 kilocalories per kg per day. That was equivalent to 1,953 kilocalories. The protein requirement, as we kept it on the objectives, but we had to move with 1.1 gram per kg per day, that is equivalent to 71.61 grams per kg per day, considering end-stage renal disease on hemodialysis. And also carbohydrates requirement, 60% of total calories requirement, equivalent to 293 grams. There was a typing error over there. The fats requirements were adjusted to 25% of total kilocalories. That was giving us 54 grams of fats. The fluid requirements were 500 to 750 ml per 24 hours, considering the patient was anuric. However, the requirements was adjusted to at most 1,300 ml per 24 hours as per dialysis adequacy, and after a thorough discussion with the doctors and nurses for these patients. And also sodium requirements were 1,000 to 3,000. That's a typing error. It's 3,000 milligrams in 24 hours. And also phosphate requirement, 10 micrograms per kg per 24 hours. That was equivalent to 651 micrograms per day. And calcium and vitamin D supplementation. So the total exchanges obtained from the calculations, the exchange calculations through exchange tables and exchange Excels. The vegetable low potassium servings were 4, fruit low potassium servings were 2, starch low potassium were 11 servings, and sugar 2 servings, protein low phosphate 6 servings, and fat had 2 servings. On the diet planning that was given to this patient, he had several meals to take, and at 8 a.m. he could take 4 medium-sized mashed Irish potatoes and 2 matchbox-sized fish that was mashed together with the potatoes. That's how he could get it. But also at 10 a.m. he had 4 pieces of mangoes and 3 pieces of pineapple. But also at 1 p.m. had 400 grams of rice, and that was 1 full bowl size, 3 browns or 2 pieces of matchbox size meat. At 4 p.m. he had a fruit salad that was half a cup of it, and also at 7 p.m. he had spaghetti or rice that was 3/4 of 500 ml cup, chicken drumstick without skin, or 2 matchbox size fish. So, and I also had a half cup of mixed cooked vegetables. All these quantifications were the spitting images of the servings that were calculated from the exchanges. So, on monitoring and evaluation of this patient, on follow-up, the patient had difficulties in coping with the quantified dietary plan. However, under effective implementation, the patient adhered to the plan and had improved from getting respiratory support and drowsy mode to fully conscious and restored and resolved difficulty in breathing. Also, improvements were evident and promising, and the patient was transferred to normal ward. However, furthermore, our patient was really getting thirsty most of the time. So what we advised him is that he could have ice cubes to lick when he gets thirsty, and ice cubes are even better for these patients because he wants to take large quantity of fluids So this will eventually help us to prevent even the progression of edema and other complications like the pulmonary edema, the lower limb edema, and so forth. So the plan was really working on this patient, and we're very happy that we could see the good results and also the changes in the biochemicals. But however, these patients need regular counseling and follow-up to make sure that these patients on end-stage renal disease are well managed and they have a good health too, just as other members. So furthermore, I would like to say dietary therapy, and we are hoping to have more cases. However, 14th March is World Kidney Day, and on the World Kidney Day, presenting on end-stage renal disease case would be very profitable, just as how we did it today. And I welcome you for comments and suggestions and questions. The comment section is all yours. You can also go through our other videos on dietary management and other case studies and also other more stuff that we have posted here in this channel. But also, I would like to say have a good time. See you next time. Don't forget to subscribe.